Hey, what's up, Trail on Volunteer Ambulance Corps? Welcome back to the next episode here, episode 18. Last time we talked about pediatric respiratory emergencies. This time we're going to talk about adult airway management and respiratory support. As per usual, take a moment to read this disclaimer. All right, so what are we going to talk about today? So we're going to talk about the concepts of oxygenation and ventilation, with the fundamental key principles in airway management. We'll talk about the anatomy of the airway and how to open the airway, as well as discuss BLS airway adjuncts and bag valve mask ventilation. And at the end, I'll spend some time talking about non-invasive positive pressure ventilation, such as CPAP, as that's sort of trickling down the line as a BLS skill. So the meat and potatoes of this, oxygenation and ventilation. If you understand these concepts, you'll be okay. EMS proverb number 1. Air goes in and out, blood goes round and round. If you have a problem, any deviation is a problem, right? And we're going to talk about the air going in and out today. That's your oxygenation, that's your ventilation. So what does that mean exactly? So when we inhale, we breathe in by negative pressure normally, meaning we suck air in rather than it being forced into us. That's going to be an important distinction. For example, when you use a bag valve mask, you're adding positive pressure ventilation. So normally we suck air in through negative pressure ventilation. That allows oxygen to get in our lungs, and when we exhale, carbon dioxide comes out. And the exhalation of carbon dioxide is what we're talking about when we talk about ventilation, okay? So you need oxygen in, you need carbon dioxide out. If you don't have those two things, you have a problem. Now, let's look at the upper airway to see how air gets in. So air basically gets in one of two ways. So you can either go in the nose, right? And look at this nasopharynx here. Look how big this area is. This is really important to understand. Or it can go in the oropharynx, and then you get down into the larynx, trachea, and then eventually the lower parts of the airway. So the second thing I want to give you guys as a pearl is put O's in the nose. And I learned this from Rich Levitan, who's one of the airway gurus. He actually runs a great airway course as well, if you're interested in that. But one of the things I learned taking his class and also then subsequently reviewing the literature on this is if you get oxygen into the nasal cavity, it fills up this area here and it almost acts like a reservoir when the patient takes deep breaths. And you can put a lot of oxygen into the nose, and so your nasal cannula is your best friend. And I'm going to talk about different ways we can use the nasal cannula in a pinch. So key point number 2, put oxygen in the nose, okay? Use that nasal cannula. Now, what are the types of nasal cannulas out there? There's your standard nasal cannula here, right? We've all, I think, know and love this one. And then there's the nasal cannulas that have the end tidal hookup. Now, most of you, including myself, when we were first taught about nasal cannulas, were taught the flow rate you could put through it is 1 to 6 liters per minute. However, in a true emergency and your patient is losing all their oxygen really fast, you can run very high flow rates through a standard nasal cannula. You could crank that up all the way to the top and run 15, 20, 25 liters per minute through that in an emergency, in a resuscitation setting. Now, this will blast air up the nose. It will dry out the nasal passageway. You cannot do this indefinitely, but you can do it in an emergency if you need to get oxygen into the patient rapidly. And then you can add a non-rebreather on top of that. So take advantage of the O's in the nose. If you're in a respiratory emergency in the crashing patient, put a nasal cannula on, blast it in, add the non-rebreather on top, and then if they're not ventilating adequately, then we can talk about bag valve mask ventilation. But even you can do that with the nasal cannula still on, giving you some passive oxygenation. Now, I mentioned you can run the high flow rates with the standard nasal cannula. The end tidal nasal cannulas, actually, this will not work. You really can't get more than 6 liters per minute, and that's because there's little specks here. You can't really see it in the photo, but that's where the oxygen actually comes out, and because this also samples the CO2 blood gas exhaling. So you're not actually able to achieve the same flow rate in one of these nasal cannulas as you can with a standard nasal cannula. So you need to, balance what you need with what you have. So in a true emergency, a standard nasal cannula is going to get you better flow rate. Whereas if you need end tidal, as you might in some ALS scenarios, then you might have to use one of these and use other methods. But just know that you're not going to be able to blast oxygen with an end tidal nasal cannula setup because the holes are smaller where the oxygen comes out. Now, the second thing I want to teach you is something called the OOPS method. Again, something I learned from Dr. Levitan when I took his course. Okay, stands for if you have someone crashing who needs to be ventilated, put oxygen on. Remember, that's going to be O's in the nose. Pull the mandible forward, meaning use a jaw thrust. And you can do a jaw thrust from the front, like you see in this photo. You can do it from behind, but use the jaw thrust as opposed to the head tilt chin lift. It's going to be your best friend here in terms of opening that airway. And furthermore, sit the patient up. Sit the patient up. If you sit the patient up, gravity becomes your friend rather than your enemy. Because what are we all tempted to do in the crashing patient? We're tempted to lay them flat and start bagging. Now, you can bag this patient sitting up, but when you lay them flat, the tongue flops in the back of the throat. Gravity pulls all the airway structures down, compressing your airway. Sitting the patient up can make a big difference and potentially turn the situation around. So OOPS method, if you have someone who is going into respiratory failure and they are still awake and they are still conscious and they are still alert, put oxygen on, O's in the nose, pull the mandible forward and sit them up. That's your first couple maneuvers here. So I mentioned some of the pitfalls with being supine. This is just kind of summarize it formally. 1, the tongue falls back. 2, I didn't actually mention this. Now gravity's going against you taking a breath because upright, you don't have this chest compression that you get when you're laying flat. You're going to have reduced lung capacity. The upper airway structures relax and compress the airway. And I should also mention this. Now the stomach is below the larynx, so this increases the risk of aspiration and vomiting. So keeping the patient upright is going to help mitigate some of these. Now, how can we keep the tongue out of the back of the throat? I think most of you at this point will be familiar with the nasopharyngeal airway. Goes in the nose, helps block the tongue from falling back here. Really great option, can be used in people who are awake with a gag reflex, which is an advantage of it. I find often patients with seizures who need some airway support, this is a great option because it gets around the clenched teeth. Versus the OPA, or the oropharyngeal airway, a patient cannot have a gag reflex in this setting. And it's going to help keep that tongue out of the back of the throat in that unconscious patient without a gag reflex. Remember that with your nasal cannula here, you cannot use this if the patient has significant craniofacial trauma. Now, how do we open the airway? So, when I was going through this, I was taught 2 methods, right? Jaw thrust for when you need C-spine and head tilt chin lift by default is sort of what I always did. What I've learned as a physician and through further practice and experience, I would recommend going with the jaw thrust every time and getting good at it. And part of the reason is, 1, it gets rid of the C-spine issue for you, but 2, you avoid the issue of the fingers compressing the soft tissues under the mandible and actually obstructing the airway. 3, you can do the jaw thrust from the front or the back very easily. And when the patient's sitting up, you can tug that mandible forward in an upright position. And so that actually is a significant advantage of that. So let's look at that a little bit further. So I mentioned ventilating upright. I mentioned certain positioning advantages. Let's look at the bag valve mask for a second and then come back to positioning. So this is your standard bag valve mask. I think all of you have seen some version of this. Note this one has a PEEP valve on it, and that's really important to help you oxygenate the patient even further. So I recommend if you don't have a PEEP valve, you should get one. We'll talk more about what PEEP is a little bit later. Now, there are a number of different ways by which you can use the bag valve mask. So one classically taught method is the CE technique. So the E is down here with your fingers. You can see it on this photo here. And the C is right here, okay? Now, in theory, this can be done one-handed. In practice, it's much better two-handed, but I'm going to show you what I think is even better than this. But this is something you should know and have in your back pocket. Whenever possible, use two hands and have someone else squeeze the bag. You will get a better mask seal. Let's compare that to the VE technique. And this is my preferred technique. So instead of the CE, you have the same E, but notice you now have a V here, okay? And the two thumbs are pressing. Now notice this can be done from behind, this can be done from the front, and these fingers here are perfectly positioned to do that jaw thrust at the same time. So you're pulling the mandible forward into your thumbs as your thumbs press the mask down onto the face. Now, this isn't just my personal preference. There's actually some research behind this. So this has actually been studied, and this was in an anesthesiology journal where they were evaluating masked ventilation, in particular in obese patients who are often difficult to ventilate. And they essentially found that mask ventilation using the modified VE technique was more effective than the CE technique in unconscious obese apneic patients. And this is the type of patient where it's hard to do this, right? So you want to get good at this scenario because if you can do this scenario, you can do easier scenarios. So again, it's not just my personal preference. There actually is some research saying, hey, this VE technique is probably the way to go. So if you've never tried this or practiced it, I recommend trying it on a mannequin first. If you've bagged before, this is not that far of a jump for you. I recommend you give this a go. Try this out on a mannequin first and then see how you like it. Now, I want to come back to something that I said on the first page when we were talking about air going in and out, and I said that we breathe via negative pressure, meaning we suck air into ourselves normally. When you start using the bag valve mask, or CPAP, or BiPAP, or intubate the patient, you are now transitioning that patient from negative pressure to positive pressure. Now, this has significant physiologic effects. Most notably, it decreases venous return to the heart, which means less blood flow to the heart, which means lower blood pressure. Okay, and this happens because of the increase in intrathoracic pressure when you pump air in via positive pressure. You must, in your resuscitation, account for this. So this may mean that you need ALS for fluids or for pressors or for something to account for the decreased venous return to the heart, which means there's going to be a drop in cardiac output. This is why when we talk about intubation, I realize that this is a BLS lecture, but it's important that you understand this because when you interact with paramedics who are going to be doing intubation, if you don't resuscitate adequately, when you intubate the patient and start giving positive pressure, they are going to go into cardiac collapse and they can die if you don't account for this. So you need to account for the decreased venous return when you switch to positive pressure. Now, EMS proverb number 3, and this was said to me by one of my mentors: do not take away the airway that God hath given you. Now, unfortunately, due to the YouTube community guidelines, I cannot show you the picture of this airway, which involves a shotgun blast to the face. So I recommend you check out the link I've included here so you can see what I'm talking about. And that patient, despite severe trauma to the face, is sitting up and breathing on their own. So if they're up and they're breathing on their own, and if you lay this guy flat, I guarantee you it's going to put blood and collapsible obstruction into the airway and it's going to be a problem. So if the patient is maintaining their own airway, don't rush to mess with it, okay? Get oxygen in the nose, keep them upright. I think a picture's worth 1,000 words here, so I recommend you just check out that link. So let's summarize what we've talked about so far. So if your patient has a problem with oxygenation, meaning they can't get enough oxygen in, they have a low pulse oximetry, sit them up, put O's in the nose, and remember you can run high flow rates, even up to 25 liters per minute for short times in a critical situation, and pull the mandible forward, aka jaw thrust. In the patient who's obstructing your airway, again, sitting up can be your friend, make gravity your friend. You have the head tilt chin lift in a pinch, but again, I recommend you get good at the jaw thrust. And you can use your BLS airway adjuncts to clear the tongue from obstructing the airway. Now, if you have a ventilation problem, meaning the patient cannot breathe adequately, meaning they are not taking enough breaths per minute, they are not exhaling enough carbon dioxide, you're going to need to use the bag valve mask to ventilate that patient. If you have end tidal or ALS has end tidals, you can use that to guide you, and you can bag to an end tidal around 40-ish. Otherwise, remember, when you start bagging the patient, you're going to have decreased venous return, worsened cardiac output, and you need to account for that. Okay? Now, let's talk a little bit about non-invasive positive pressure ventilation. So, what is that? So that's CPAP, that's BiPAP. I want you to imagine, when you stick your head out the window and the air blows in your face, that's essentially what that is. That's essentially that machine essentially just blowing air continuously in your face. Now, if it's a CPAP machine, it's a continuous pressure. If it's a BiPAP, and again, BiPAP actually refers to a commercial product, so I'm going to also use the word BPAP, which just stands for any generic setup. And this is a common setup that is used in the pre-hospital setting. That can actually put an inspiratory pressure and then hold an expiratory pressure, so there's two levels. I'm not aware of any BLS agencies using BiPAP, so you can focus mostly on CPAP for the purposes of this talk. Now, what are the advantages and disadvantages of each type? So CPAP improves oxygenation. BiPAP improves oxygenation, but it can also improve ventilation because it's got a difference between the inspiratory and expiratory pressure. Now, CPAP gives you PEEP. What is PEEP? PEEP is positive end expiratory pressure. That is the pressure that is still present at the end of expiration when you breathe out. Now, there are advantages of this type of pressure. One, it decreases preload and afterload. This is really helpful in someone with severe CHF, for example, and crashing pulmonary edema. CPAP is also easier to use, more available. BiPAP does the same thing, gives you the PEEP, but you also get that driving pressure, which can help clear CO2. Has similar effects on the preload and afterload, and you can set a backup ventilatory rate on it, but the patient still must be spontaneously breathing on their own to use these. Now, why does CPAP help you out? Why is the PEEP good? So CPAP, it puts oxygen in, it gives you PEEP, and also you can run nebs and other things through it. So it is a medication delivery system too. Now, what is this PEEP that I'm talking about? No, it's not the chewy marshmallow delicious candies. What it really is the pressure at the end of expiration. So when you breathe in and out, what can happen is your alveoli, which are the little air sacs that collect the oxygen in your lungs, they can collapse, sometimes also called atelectasis. And if they collapse, you're going to have less oxygen diffusion, there's less surface area for oxygen to get in, and you're going to need a higher pressure to re-expand them. And this constant opening and closing of them can lead to what's called atelectotrauma, which can hurt these guys. Now, if you have good PEEP, meaning there is still some pressure left when you breathe out, the alveoli stays open. You don't have to open and close it. You can diffuse oxygen better, and you don't need as much pressure to re-expand the lung on the next breath. So this gives you the several advantages, and that's why PEEP's important. So PEEP keeps the alveoli open, it facilitates oxygen diffusion, and then you don't need as much pressure to reinflate the lung on the next breath. So that's the importance of PEEP. Now, when does this really matter? Well, one, I mentioned CHF because it'll help reduce that preload, afterload. The PEEP is going to help you oxygenate these patients, especially if they have a lot of pulmonary edema. Reactive airway disease or obstructive airway disease, asthma, and COPD. In particular, COPD really benefits from this. And there are more, and we can't talk about all of them today, but one of the other ones where it can really matter is obesity hypoventilation syndrome, which is where the weight of the chest is so much that they actually get a little hypoventilation. So CPAP can really help with that. Non-invasive can really help with that. Now, are there any patients where you can't put this on? So one, the patient has to be breathing on their own. So you cannot do this in respiratory and cardiac arrest. It is the wrong modality for this. It doesn't matter that the BiPAP has a respiratory rate. You should be bagging the patient with a bag valve mask. If you're in cardiac arrest, you should not be using this in respiratory or cardiac arrest. Now, again, I can't show you the anatomy of this traumatized airway, but if the facial structures are not intact, you can't put this mask on. If you look at this picture, you'll see very clearly you can't put this mask on this guy. Now, secretions. So one of the challenges with this mask is when it goes over your face here, the patient has to be able to get it off to clear secretions like phlegm and vomit and stuff like that. So if the patient can't do that, that could be a problem. Now, sort of corollary to that is the patient with altered mental status or who is at risk for aspiration. Again, if they're at risk to vomit and cannot take the mask off themselves, they're potentially at risk to aspirate. Now, patients who have altered mental status are at risk for this. Now, the textbook answer is you should not put non-invasive ventilation like CPAP or BiPAP on a patient who has altered mental status. Again, that is the textbook answer. However, in a true emergency, I have used this, and I think many practitioners use this in the patient who is slightly altered, because sometimes the reason they're altered is that they don't have enough oxygen or they have too much carbon dioxide. And by putting them on non-invasive, you cure the problem. They actually get better. They wake up and you avoid intubation, which is a bad outcome for them, and they end up on a ventilator, etc. So, if you're going to do this in that situation, you must be the one to monitor the mask and clear it and clear the secretions and stop aspiration. Again, that's not what the textbook will tell you to do. However, I want to give you practical pearls that could really help a patient in a pinch. So, in a pinch, you can trial non-invasive in a patient with mild altered mental status as long as you're watching them like a hawk and can get that mask off if they start to vomit. Okay? This is especially helpful in a patient, for example, with bad COPD, and they have a little bit of hypercarbia where they're not quite ventilating well, and this will actually fix them and help avoid intubation, and so that can be a real advantage, but you have to use extreme caution. I'm saying this online, so I'm saying very clearly this is not the textbook answer. This is something that is, you know, being worked on by providers in the field, and many people will try this, but with understanding what they're doing, understanding that you have a risk of aspiration. You're calculating the risk-benefit ratio in terms of the harm of intubating the patient and avoiding that. So you're really looking at this and thinking about it thoughtfully if you're going to do this. But the standard answer is you're not going to do this on someone with altered mental status. So summary. CPAP and BiPAP give you oxygen and they give you PEEP. And that's the way they help your oxygenation problem. PEEP keeps the alveoli open, giving you more alveolar surface area for oxygen diffusion. So it helps you get that oxygen in. COPD and CHF are the ones I want you to think about first when you're thinking about CPAP and BiPAP, but other patients may benefit as well. And with that, I hope that you found this helpful. Doc Vader, who, if those of you haven't seen this, I'm sure you would enjoy some of the comedy from Z-Dog Medical, who has the Doc Vader cartoon. So shout out to Z-Dog for his caricature. Stay safe out there, guys. Use non-invasive. It can really help you out. Peace out.